Thank you so much, sir. Am I audible, sir?
Yeah, you are audible, Rajesh.
Very good evening to all. In next 20 minutes, I'll be discussing about management of locally advanced prostate cancer and recent updates. I'll share the slides. Sorry, I'm not able to share this slide. Can you please share it for me? Hello.
Yeah, Aru, do we have Amit's slide? Yeah, here it is, sir. This is Rajesh now.
Yeah. Thank you. Next slide. As per Globocan 2020, prostate cancer constitute 7.3% of all new cases and 3.8% of all new deaths globally. It is predominantly a disease of elderly, and maintenance of castrate level of testosterone is the foundation approach for all prostate cancer disease state, where it be localized disease or a non-metastatic CRPC or a metastatic prostate cancer, which can be hormone sensitive or a castration resistant prostate cancer. Next slide. So careful risk stratification is very much essential for management of prostate cancer. This helps in appropriate selection of therapy for consideration of this slide is only partially visible. Or for this helps in the careful selection of therapy and for better pre-treatment counseling of the patient and for selection of patient for clinical trials. Various parameters used in the risk stratification are serum PSA, Gleason score, and T staging. When it is used in combination, it is better than using it as alone. Next slide. So generally for risk stratification, we have a low risk, intermediate risk, and high risk patient based on PSA level, Gleason score, and the T staging. Next slide. So we have various risk group stratification as per NCC and ESMO and EAU guidelines. So these risk stratification model, these risk groups are quite heterogeneous groups. So like NCC and they have divided low risk into very low risk, high risk into very high risk, and intermediate into favorable and unfavorable intermediate risk group. High risk group itself is a heterogeneous group. We have on one side high risk patient who behaves better with multimodal treatment, and on other side high risk group patients with very high risk of progression, metastasis, and biochemical relapse. Next slide. So there is no definite consensus regarding the definition of locally advanced prostate cancer. So we define locally advanced prostate cancer as prostate cancer more than T3 or more, that is cancer with extra capsular extension, cancer invading the seminal vesicles, or cancer invading the adjacent organ with nodal or with the nodal involvement, irrespective of PSA level and Gleason score. Next slide. In the diagnosis for detection, characterization, and local staging of prostate cancer, there is a definite role of multi-parameter MRI. It enables reliable detection of clinically significant prostate cancer, and it is currently the leading imaging modality. Next slide. So for the treatment of locally advanced cancer, it's basically a multimodal treatment where we have radical prostatectomy, neoadjuvant androgen deprivation therapy, radiotherapy, adjuvant ADT, and the emerging role of adjuvant chemotherapy also. Next slide. So the present guidelines says there are 3 modalities which are used in the management of locally advanced prostate cancer. The available options are EBRT plus brachytherapy boost or EBRT alone, both in conjunction with long-term androgen deprivation therapy, and in carefully selected patient, radical prostatectomy with the extended pelvic lymph node dissection with post-operative adjuvant RT and androgen deprivation therapy. Next slide. Radical prostatectomy, we have many retrospective cohort studies where radical prostatectomy is used as a part of multimodal treatment. It has shown that there is a definitive improvement in the 10-year cancer-specific survival of around 87%, 15 years cancer-specific survival of around 60%, and 10-year OS of around 75%. Next slide. So in carefully selected patients, that is in young patients with no too much fixity of prostate to the surrounding tissue, and especially in patients with non-cancer lower urinary tract obstruction, which is not responding to medical therapy, radical prostatectomy is one of the options. Next slide. Role of EBRT or alone or EBRT with the ADT is also there in management of locally advanced prostate cancer, and ADT in combination with LHRH analog plus anti-androgens is used as initial or adjuvant treatment as well as post-prostatectomy failure cases in the management of locally advanced prostate cancer. Next slide. Is there any role of neoadjuvant androgen deprivation in patients prior to RP? Neoadjuvant androgen deprivation can decrease the post-operative positive margins. It can reduce the tumor bulk. It can decrease the biochemical recurrence. But there is no improvement in OS and cancer-specific survival. So it use as a routine thing is not generally recommended. Next slide. Adjuvant radiotherapy, it reduces, especially when combined with the brachytherapy boost, it increases the dose to the prostate and minimizes the radiation to the surrounding tissue, thus reducing the adverse effect of RT. Next slide. Role of cystoprostatectomy in the management of locally advanced prostate cancer. We have systemic reviews. Next slide. So we have in that systemic review almost 7 studies with more than 200 patients. Cystoprostatectomy was done as a primary modality in locally advanced prostate cancer or as a salvage procedure. And next slide. So perioperative outcome pathological results are blood loss volume generally between 2000 to 5000 ml, and operation time generally from more than 8 hours, 8 to 9.5 hours, with a positive surgical margin seen up to around 60 to 70% of cases. And bladder invasion were seen in almost up to 80% of cases. All these patients had a Gleason score of more than 7, and there was an overestimated T-score of up to 60%. Next slide. So post-operative complication and survival outcome seen that the complications were seen up to 75% of cases, and distant metastasis were seen in around 77% of cases on more than 60 months of follow-up. 5-year cancer-specific survival was 87%, and 5-year biochemical progression-free survival was 62%. Next slide. Role of robot-assisted radical prostatectomy. Next slide. So here the blood volume loss is less compared to radical prostatectomy, which is around 400 to 500 ml. Complication, all grade complication at the rate of 8 to 29%. And oncological outcome, most of these patients were continent at 1 year, and almost the biochemical relapse-free survival were 50% at 1 year. Next slide. Role of androgen deprivation therapy in locally advanced prostate cancer. Next slide. Next slide. So, how to give ADT, whether immediate or delayed of ADT? Is surgical better than medical castration, or is it equivalent? Selection of agents, agonist or antagonist. All agents are equal or not? Role of combined androgen blockage and intermittent androgen blockage, is it safe or not? Next. So surgical castration as compared to medical castration, we can achieve castrate level of testosterone rapidly. Since there is no testosterone surge, there is no flare, so no prior anti-androgen required. And the issue, it is cost effective, and psychological element is there, since surgery is done and scrotum is testis is removed. Medical castration on other side is the castration level is achieved late at the end of the 3 to 4 weeks only. There is a testosterone surge, and so flare can occur. So anti-androgens may require prior anti-androgens. Next slide. Both are equally effective. And compared agonist with antagonist, antagonist has a rapid onset of action of the castration level is achieved within 96 hours. No flare. PSA failure rate is 8.9% only compared to 14.1% with agonist. But there is a significant local injection reaction of up to 40%. Cardiovascular complication is almost similar. Antagonist is administered monthly, and the antagonist can be given for selected patients who needs rapid onset of action. That is the patients who present with severe symptoms or impending spinal cord compression, severe bone pain, or bladder outlet obstruction. Next slide. The role of adjuvant ADT, long-term adjuvant ADT, long-term ADT improves the overall survival. It potentiates the radiation effect. It helps in the eradication of microscopic distant metastasis outside the primary. Next slide. So, regarding the optimal duration of ADT, there is no clear definition. Generally, in high-risk setting, long-term ADT is used. 18 to 36 months is used. This has got a longer biochemical failure-free survival and a significant OS also. Next slide. So ADT in combination with RT, this is the main stay of treatment of locally advanced prostate cancer. There are various trial RTOG, RTC trials. RTOG 8610, which evaluated ADT plus RT, that is 2 months prior to RT and 2 months post RT, ADT was given. And compared to the RT alone group, the combination group, there was a significant reduction in disease-specific mortality, distant metastasis, and biochemical failure rate were also less in the ADT plus RT group. In ERTC 22863 and RTOG 8531, the duration of ADT was prolonged almost 3 years and more. Here also there is a significant improvement in the disease-free survival, overall survival, and cancer-specific mortality improvement is also there. Next slide. So long-term ADT is better than the short-term ADT. So long-term ADT is generally 18 months to 36 months. Generally, most of the guidelines recommend 24 months of ADT. So the main problem with the long-term ADT is the side effects. It can be impotency, loss of libido, osteoporosis, so many side effects related to androgen deprivation. So this was compared long-term ADT 36 months with the intermediate term of 18 months. After 9.4 years of follow-up, there was no difference in distant metastasis, overall survival, and cancer-specific survival. These patients had significant improvement in quality of life. So intermediate ADT might be non-inferior to long-term ADT of more than 36 months, but this should be tested in a properly powered non-inferiority trial. Next slide. So RTOG 8610, as we have already discussed, randomized locally advanced prostate cancer. 1:1 randomization was done with ADT, 2 months prior and 2 months post RT, and RT alone. Next slide. Next slide. Next slide, please. So there is a significant improvement in the disease-specific mortality, as we see that there is a wide separation of curve in the ADT plus RT group compared to RT alone, and prostate cancer specific mortality is also significantly increased. The 10-year at 10-year, only 23.3% died of prostate cancer in the combination group compared to 35.6% in the RT alone arm. In the RTOG 96101 trial, there was 51% reduction in risk of prostate cancer specific mortality over 10 years in the combination group. Overall survival, again, there is a benefit, and all-cause mortality also, there is a significant improvement in the combination arm compared to RT alone. Next slide. GETUG AFU 16 trial, which randomized post prostatectomy failure patients with the rising PSA. They randomized 1:1 randomization done with 6 months of ADT plus RT or RT alone. Next slide. Next slide. So there is a significant improvement in progression-free survival. 10-year progression-free survival was significantly increased, 64%, 10-year progression-free survival compared to RT alone. Next slide. Role of adjuvant chemotherapy, the multi-arm, multi-stage Stampede trial, they had one arm with docetaxel, which was given before RT and long-term ADT. There was improvement in PFS and failure-free survival, but no significant improvement in overall survival. So this is under evaluation and investigation, and there is long-term follow-up is required to see where there is an overall survival benefit in this subset of patients. Next slide. So to conclude, in carefully selected patients with locally advanced prostate cancer, radical prostatectomy is one of the modality which can be tried as in a multimodality setting. There are newer options like robot-assisted radical prostatectomy, which helps in the management, which has better post-op outcome compared to radical prostatectomy. And ADT in combination with primary therapy has shown to improve improve the outcome significantly. Long-term ADT has shown clear benefit over short-term ADT. The role of neoadjuvant chemotherapy is under investigation, and there is not enough mature data to encourage the general use of adjuvant chemotherapy in a multimodality treatment setting at present. Thank you.
I must congratulate Dr. Nair for that lucid presentation. He's included everything in his crisp and precise presentation. It was a very nicely concluded and nicely brought out. He has gone in the details of all the recent advances and the recent recommendations. It was very nice. Thank you so much, Dr. Nair.
Thank you, sir.
And now I'll not stand between the audience and our great stalwart, Colonel Chaudhary, sir. We associate long since past, and I know he'll carry this show forward with a lot of learning again. Over to you, sir.